I'm Sarita Verma. I'm the Deputy Dean of the Faculty of Medicine and the Associate Vice Provost for Health Professions Education at the University of Toronto. And on behalf of the university, the faculties of health sciences, on behalf of the Department of Family and Community Medicine, of which I am a proud full professor, I would like to welcome you to this incredible event. The talk by Paul Farmer from Harvard Medical School, Social Justice and the Movement for Global Health Equity. So I just want to open a little bit with some reflections on how global health has made its journey here at the University of Toronto. Some of you may remember many, many years ago, we had a Center for International Health, which kind of dissipated in osmosis into the never-sphere. And in 2010, we began deliberating what it meant to be involved in global health, and in fact, the intersection of global health with international relations. I was very much the advocate at the university level and the faculty level to bring together some of our most remarkable leaders, many of whom are here in this room, to craft the Global Health Roadmap, which then became the marker and the benchmark for our performance across the Faculty of Medicine, and it was led very much by the Department of Family and Community Medicine. Since then, in fact, this journey, we've been joined by the emerging Faculty of Public Health, which has taken on global health as one of its key divisions and its key areas of theme. And indeed, we've observed the proliferation in the last 4 years, remarkably, of a commitment to social responsibility by the University of Toronto, for which I have to say is a bit of a legacy piece and something I'm incredibly proud of. And you will ask yourself, why did this happen? Why did it happen now? Why are you here today? Why are we actually talking about these things? And those questions I want you to pose to Paul Farmer. What is it all about? Why is there such a hunger amongst all of us to deal with global health? And why are we inspired by it? In my journey working in UNHCR in Ethiopia and Sudan and in many parts of deep, darkest Drakensberg Mountains of South Africa, one of the things that I have learned and brought to my work is that health knows no boundaries. Regardless of emerging infectious diseases, in fact, we are all challenged with an aging population, mental health issues, urbanization, poverty, and indeed all of the things that I think everyone in this room cares about deeply, passionately. And so today is an amazing opportunity for us to, in fact, thanks to people like Catherine Rouleau, Lynn Wilson, Howard Hu, and all of the organizers, Jamie and Cecil, for organizing this particular event, that we are now able to open, I think for one of the very first times in the history of the University of Toronto, a complete dialogue with someone who can help us navigate through this journey. So welcome on behalf of the university, on behalf of the faculty, and my favorite department, Family and Community Medicine. Thank you for being here tonight. I'm going to introduce Catherine Rouleau, who's going to introduce our speaker. Thank you.
Thank you, Sarita. My name is Catherine Rouleau. I'm the director of the Global Health Program for the Department of Family and Community Medicine. And it is my exquisite privilege and pleasure to welcome all of you to the very special and last edition of the Global Health Speaker Series of the Department of Family and Community Medicine. If it's true that when you're a hammer, everything looks like a nail, it is also true that when you're a family physician, the world looks like a family. And if not like a formal family, at least like a very intricate and kindred network of relationships. And this is certainly true of our perspective on our friends at Partners in Health. I realize that I am standing between you and 3 fabulous speakers, but because I am not only a family physician, but I am a French-Canadian family physician, events like tonight feel like a family gathering. The kind of family gatherings that are full of joy and celebration, but also the kinds of family gathering where serious issues are discussed, where people of like mind debate, discuss, converse. And because the very best family parties where I come from are the ones that are not bounded at the end by official thank yous, I will ask you to indulge, and I will ask our distinguished speakers to indulge me in acknowledging a few of the key individuals and thank a few individuals who've been instrumental in putting this evening together. First and foremost, I, of course, would love to thank and acknowledge the great privilege given to us by Partners in Health, and specifically by Partners in Health Canada and our good friend Mark Brender, for giving the Department of Family Medicine the opportunity to host this event tonight. I would also like to acknowledge the Office of Strategic Communication and External Relations, OSCR, of the Faculty of Medicine, for their support. I'm looking for them. Now everybody looks different. There's Simona Powell and the lovely team who accompanied us earlier today. Thank you for your support and your investment in this event. I would like to thank all of you in this room for accepting the invitation so bravely, and I would like to acknowledge all the people following us on a webcast live around the world. To my parents in Montreal, hello Mom, I hope you're well. I hope she's figured out the computer by now. But this is also my clue to actually tell you, for those of you who are of the generation before mine, although I realize others much more savvy than I, of older generation, also use Twitter. You can follow us on a number of hashtags, hashtag family medicine, hashtag social justice, hashtag equity, and hashtag Paul Farmer. I can't figure out whether you're laughing because of the hashtag or the hashtag. The French just takes over, and I'm just going to say it quickly and pretend nobody heard this. I would like to follow with the acknowledgement and the thanks to the Dalla Lana School of Public Health, who, and especially Howard, who I'll get to introduce formally in a minute, to this great family who is going through a renewal for their role and continuing their role as beacons of global health in our great faculty. Thank you to the Dalla Lana School. And I have to say this about the Dalla Lana School, you know, if this is a family reunion, then our friends in public health are a little bit like first cousins. They're different enough that you find them mysterious and intriguing and fun and sometimes a little bit daring, and they're familiar enough to know, for you to know that when the going gets tough, they're like you enough and you're going to stick together, and you're in fact very much family. So it's great to be part of this event with you. And of course, my very own professional family, the Department of Family and Community Medicine, all of you who are here and who've supported the efforts of the Department of Family Medicine. I want to point out in a very special way the volunteers from the DFCM who have enabled us to actually put this evening together in a very, very special way. I see Jamie Rose Rodas at the back, and I do not see Dr. Paula Godoy Ruiz, who's there at the back. And please stand, actually, Paula and Jamie. I don't know if it's a point of pride for me to say that we have a PhD in anthropology organizing events like that, which certainly speaks to her affinity for a discipline like family medicine in the multidisciplinarity that she encompasses. But both Paula's expertise in anthropology and Jamie's exquisite skills in everything, expertise in global health and program planning, deserve recognition. And last but not least, I do want to bring to mind and acknowledge the members of the family who are not with us this evening. Those are the Chimwemwes, the Marys, the Wendys, the many people in Haiti, in Rwanda, and around the world, those individuals, the mothers, the fathers, the children, who inspired the work that we do in global health, and who stand as constant reminder of that dreadful inequity divide that we all work so hard to address. Ultimately, what brings us here today, I think, is this common goal to address inequity in health. And though it might seem strange in an environment as rich in global health activities as the University of Toronto, that the Department of Family Medicine might host an event like this, I think that two things actually make it a particularly appropriate host for an evening with Partners in Health. And these two things are the demonstrated impact that family medicine has on equity and our continued investment in addressing equity as a discipline, and the fact that fundamentally we are all about relationships, that our discipline cannot exist without partnerships with the community and with individuals who trust us. And so on that note, it now gives me great pleasure to introduce our three speakers. The evening will go as follows. Dr. Paul Farmer will speak for 30 minutes, or 30 farmer units, as I understand we call them. They vary around the world, and I, for one, will not stand in the way of that adaptability. His presentation will be followed by a shortish but a valuable presentation by Dean Howard-Hu of 10 minutes, and then Dr. Lynn Wilson for 10 minutes. But then, very importantly, we will open the floor to your discussions. This is meant as a conversation. I will tell you again later, but the important thing for this conversation is for you to make your way to the microphones to ask questions, because unfortunately, your questions will not be broadcast through the webcast if you do not come to the microphones. And so I will introduce our speakers in reverse order, and then we'll ask them to join us on the stage. I have a long biography for Lynn, but here's what I'd like you to know about her. She's a full professor and the chair of the Department of Family and Community Medicine at the University of Toronto. She has many areas of expertise, having practiced as a comprehensive family physician. Her areas of special expertise include palliative care, addiction medicine, obstetrics, and global health. She has been a leader, a mentor, and a strength in the development and strengthening of our discipline, not just provincially and not just nationally, but internationally, and it is a great pleasure to have her as a speaker today. Dr. Howard-Hu, who some would say is a newcomer, although this is less and less true, less and less of a new kid on the block, came to us in 2012 as the inaugural dean of the Dalla Lana School of Public Health. He's a professor of environmental health, epidemiology, and global health. He's a physician scientist. He was trained as an internist and an occupational and environmental medical specialist. He has led multi-institutional and international teams of scientists devoted to environmental, nutritional, social, psychosocial, genetic, and epigenetic determinants. He's on the board of directors for Physicians for Human Rights. He is a leader, a beacon, a productive cage rattler and innovator in our great global health environment, and it is indeed a privilege to have you to speak with us today as well. And last but not least, who needs introduction less than Dr. Paul Farmer? Dr. Paul Farmer, as you well know, is the Colocotrones University professor and chair of the Department of Global Health and Social Medicine at Harvard Medical School. He's the chief of the Division of Global Health Equity at Brigham and Women's Hospital in Boston. And of course, he's the co-founder of Partners in Health. He described himself earlier as a teacher, as a learner, and as an anthropologist. For us, he is now a family member and a colleague and a friend. And on that note, I would like to invite all three of you to take place on stage. Thank you.
I'd be too nervous, you know. And that's a bad sign for all of you worried about what a farmer unit might be. Because the more nervous I get, the longer it will get. And I have exactly 30 minutes. Really? I have all that time? That would be great. I also want to say thank you. And Catherine, thank you for the introduction. And I really dig your fluency. You can do all that without any notes. Of course, I'm already trying to wonder, how does she do it? Does she memorize it? And also, you know, to be a guest here in family and community health, community medicine is meaningful to me for reasons that I'll get to mention. Speaking of family practice, I would also like to, you know, mention and thank my colleague, Dr. Caroline Israel, who is right here, has been the director of a residency program, one of the residency programs, several that we've launched in Haiti, and I hope you'll get to meet her, my colleagues, Mark, Emily, Marika, Andrew, in the course of discussions tonight. Now, I'm just gonna, I have to admit, when I was on my way here, before I looked at the title of the talk, that I don't know how you extracted that kind of a title from me. I know, but I'm not sure exactly filtered to me, because I thought, really, did I say that I would talk about social justice and the movement for global health equity? That's a little bit immodest, but I care about these things so very much, and so I'm happy to launch a discussion. As I did say, I'm a teacher, but also someone who's trying to learn. These are very difficult topics for practitioners, for physicians, nurses, social workers, psychologists, pharmacists, managers in the front lines of global health. And again, remember that global health does not mean international health. When we're talking about various paradigms that rise and fall inside medicine and public health, I would say that international health is one of them that has fallen, and it's okay, because there are confusions that occur in using the nation state as your unit of analysis that don't occur or don't necessarily occur when we're talking about global health equity. I mean, Toronto's on the globe. I just came from Chicago. I'm sure you've all been, you've all done what I did, which is go from Siberia to Haiti to Chicago to Toronto. And all these places on the globe. So global health equity as a term was really rather a conscious, in my experience, a conscious reaction to previous paradigms of thought that included colonial medicine, post-colonial medicine, the rise of international the rise of international health, and the fall in aspirations for equity. Some would argue if you compare the end of the 19th century to the end of the 20th century, you'd see lower aspirations in international health or international public health than you would have seen 100 years previously, when public health was tightly linked to the notion of social justice. So you ask, what is it that draws so many people, young people especially, and I'm very grateful to see so many here today, to global health equity? I would hazard the guess that it's really the equity part. People have always been interested in health and well-being, right? But equity, the disparities that Catherine mentioned in her introduction are shocking, and they're also less easily hidden away in a global era. So let us hope that I'm right, that inequality, which is rising over time, it's obvious what we say on my side of the border, in your face nature, will make us contemplate what it is we're going to do to address disparities of risk and also of access. And I'm not just talking about healthcare. Just this rising inequality is terrifying to contemplate, not just from a place like Rwanda or Haiti, but from within affluent nations, which do not have brakes on growing inequality. So that's the background, the big picture question that I'll ask as I return to very specific examples. And although Catherine didn't mention it, I'm an infectious disease doctor, and as some of you know, we tend to focus on the real minutiae. Come on, this is a little bit funny. You know, I've noticed there's a very serious crowd. Lynn and, I mean, the students I met with this afternoon, they're really intense and serious. All right, examples. And I just start with this because I'm going to contrast this big picture claim, which I think some of you will recognize. We've all used this many times. What is it that Martin Luther King is getting at here? That inequality is shocking, but these kind of disparities in healthcare or health in general. And he says healthcare for a reason, by the way, right? Because although we can argue and will, no doubt, tonight, or think about the social determinants of risk and for illness or well-being, and we talked a little bit about this, Alex, on the way over here. We can talk about it a lot, and we should, but disparities of access to health care, it's not as if these are beyond human control, right? There's no credible claim that could be made to that end. So I think there's a reason. Now, in very different language, and I've had the occasion use this language in my work that goes between a place like the Brigham and Women's Hospital or Harvard Medical School and, let's say, someplace in rural Haiti. I haven't quite mastered this technology. Here's the 3 Ds that we've been talking about for a long time. What is it that academic medicine agrees upon? That we're going to be focused on discovery, in the sense a lot of the tools that we use, whether you're talking about a preventive, like just say HPV vaccine, whatever comes into mind, or a diagnostic, or a therapeutic, go right through your own list. A lot of the work really comes, starting at least in the middle of the 20th century, from basic science discovery, and we need that, and it's front and center in a lot of medical schools in the world, which is a good thing. Development, sometimes that gets pushed out, or as we say in Boston, turfed to the private sector, pharmaceutical companies, for example. And some things get developed that probably shouldn't, and other things that need to be developed don't get developed. It's an imperfect way of doing it. But no one disputes that it is important to develop the discoveries. And then the third D, which is what a lot of us focus on, is either delivery of services. Again, services can be prevention as well as care. And to find out, to study that as we're doing it, because we believe, again, not an original idea, the Enlightenment folks seem to believe it, that we can actually improve health outcomes. And again, if you're particularly fond of upstream determinants of healthcare, run that list there as well, as a nod to my pal, Howard Hu. Think about environmental health. Think about any kind of matter that's important to you. You can usually think of ways to focus on the delivery of something good. Now, I'm going to skip ahead to an example, one that will be familiar to some of you, or most of you, I think, and the reason that I went into infectious disease, and that is chronic infectious disease. I could now tell this story in a very exciting, upbeat way about hepatitis C, right? I think it was 1986 when hepatitis C was discovered. Certainly it was while I was in med school, and I started in the fall of '84. And again, we don't have a vaccine yet, right? The diagnostic took a while to develop. It's pretty good. A lot like HIV testing, right? Viral load, serovars. But what's really exciting now is that we have new therapeutics that can move from a pretty mediocre, when I was infectious disease fellow, first of all, I was gastroenterologist, and I know a couple of you are gastroenterologists, who managed HCV, chronic HCV infection. Very bad treatment in the sense of side effects, poor outcomes. That's all about to change. Indeed, some of us are argued that over the last year, we've reached a 1996 moment. Now, those of you who've been involved in AIDS activism, say, or actual delivery of services for people living with HIV disease, will probably recognize that reference. Why did I say 1996? In 1994, in the late 80s, if I could just go back in time, the late 80s, when I was a medical student, and the early 90s when I trained at the Brigham, as did, where Howard also worked, the leading infectious killer of young adults in the United States was HIV disease. And the wards at the places where we trained, the Mass General, the Brigham, the Deaconess, the Beth Israel Hospital, there were people, young people, dying of AIDS there all the time. And that was, in fact, very often a mode of exit in a hospital, with a very difficult course. By the time I started an infectious disease or finished an infectious disease fellowship, people started on these so-called ART cocktails, got up, went home, and that was a pretty remarkable transformation. So by 1996, it was quite clear that we had not a cure, but an effective suppressive therapy. And again, it was actually available pretty easily. A multi-drug regimen, oral. Does that sound like another chronic infection? Not just hepatitis C going forward, but going back, tuberculosis. And this is very much the way that chronic infections should be treated. If you're lucky enough, you can cure them, tuberculosis, HCV. If not, we need to develop effective suppressive therapies. Now, there went in that year, in fact, that's the last time someone asked me, have you ever been to Toronto? This is yesterday. I said, yes, I have. I'm a well-traveled American. I've been to Toronto, Montreal, and I went on and I started hemming and hawing. Okay, I haven't been to Sherbrooke, but I'm going to, Professor. But in 1996, I went from Haiti to Vancouver. And some of you, I'm just curious, is anybody here at the AIDS meetings in Vancouver in 1996? A couple of you. And I thought, I don't really know if I want to go all the way from Haiti to Vancouver. I wish there had been direct flights for one day of meeting. In fact, we had just published our best-selling book, Women, Poverty, and AIDS, even with a great subtitle, Sex, Drugs, and Structural Violence. 1996. I see you missed it. And I was going to launch that book. Just say it, failure to launch, I believe is the. And I just remembered thinking, so the theme that year was one world, one hope, and I was making impolite retching noises into that could have been air sickness between Haiti and Vancouver. But I remember some people who were from that country, some of our politicians called the country of Africa, not really a country, were doing a demonstration with a banner that said, "One world, no hope," because they knew that this was going to be a long struggle, and probably they knew that there hadn't been an example of using a 1996 moment wisely, where you've actually developed something and have an equity plan. So the movement from optimism to pessimism, let me just show you one example from an American news magazine, meaning the other side of the border. The end of AIDS, this is 1996, and then 1997, an article just a year later that says, too poor to treat. They weren't talking, and these perceptive journalists were not talking about people living in sub-Saharan Africa. They were talking about Americans, living in U.S. cities and other regions that really were non-compliant, non-adherent, the list, right? Family practitioners happily use some of these terms a little bit more critically. But there was a big challenge. How are we going to reach people who are marginalized by racism, poverty, gender inequality, and sometimes the most crass kind of privation that you can imagine, and with which I was familiar as a clinician. Now, I was told, by the way, in a talk I gave, before a talk I gave yesterday by some of PIH Canada, that said, Canadians like things to be upbeat. And also Canadians, I like this. By the way, this is someone with anthropological training, willing to class all of your vast nation as Canadians. And they like things to be upbeat and don't hesitate too much, because then they'll go, yeah, that's all well and good, but. That was the advice I got. Thank you. So this is where we sat. This is not that long ago. I took out the names of the people speaking because these are people I know, right? It's and as I get older, it happens more and more, right? You realize it's your peers and friends who are making these claims, right? And so the 1996 moment dragged on, and it was the biggest problem, the biggest obstacle to delivery of care for this chronic illness was not that there was no delivery platform, right? That's why God created community health workers. Did God create community health workers? I have to check with never mind. In any case, there was a way to do this. Right? Same thing we did a plan to reach from, for example, a hospital or clinic into homes. There's no reason to not expect rates of response. They're just as good as in any clinical trial. In fact, better, right? Because it's convenient for the patients, brings care to them. I'd make the same claim, by the way, about epilepsy, which is a ranking problem in many of the settings I work, and we don't have people prescribing those kinds of medications, again, a chronic ailment, with the help of community health workers. Now, these were claims that this could have gone either way. This went on for years. And again, many of you will know the history. I know I've met at least one faculty member who's been studying this from a human rights angle. This was bad enough just to read on intellectual grounds, almost appalling to read these claims that were not buttressed by any clear data. They were really sort of ideological or claims that were elevated to the level of policy. Not that that ever happened before, right? But this is kind of what was going on. This was from the World Health Organization report in 2001. ART, that means the therapy, antiretroviral therapy, the only one we got, right? So if someone's saying, well, usually if you say, well, we have to compare two therapies, right, to see which one might be more effective if you're talking about cost effectiveness. But here we're talking about therapy versus no therapy. Well, how do you think that's going to play out? It's like food versus no food. Unfortunately, humans have this annoying habit of needing to be fed every day. See, the Toronto crowd is really, I get it now, it's just like they're not sarcastic, right? So anyway, it was imagine you're in the middle of going between Harvard and Haiti, as I was, or Harvard in South Africa, right? And you've opened the door because you have a model of care, like a family practice model that goes from community health workers to clinics to hospitals. It's not rocket science. If you want me to stop so you can take down notes, right? Community-based care, clinics, that's where the majority of healthcare can be delivered, by the way. And then for those who have troubles, like people who get critically ill if you open the doors, right, if you say, you know what, it's not going to be your poverty that determines whether or not you'll have access to medical care. If you open the doors, we know what happens. I've never not seen this happen, by the way. This is actually a place called Las Cobas, 2002, the first global fund-supported AIDS program in Haiti. Now, interestingly, the Global Fund did not disperse the money on time. Well, Partners in Health had a little dilemma. What do we do, right? We told everybody that we're opening up this abandoned public clinic and making AIDS treatment available there, but this new mechanism, the first of its sort, hasn't really dispersed anything. So we did what any self-respecting NGO would do. We took out a bank loan at commercial rates. And we had to get our chief donor, by the way, to co-sign, which kind of is demeaning after 15 or 20 years in the business. But I'm glad we did because a lot of lives got saved. And sure enough, people came along. And as a tribute to some of the AIDS activists who moved this forward to the 1996 moment, at least, although it didn't occur in 96, 97, 98, 99, 2000, 2001, think of all the people who died, I guess from lack of access to many things, right? But this is a set of oral treatment, And again, there are many, many ways to die, but the biggest one is really this lack of a global health equity. How does anyone die in a third trimester catastrophe? Right? I mean, it's not because we don't know how to manage them, we, the collective we. How does anyone die of a seizure disorder? It's not because we don't have seizure diagnostics or therapeutics. It's really, again and again, the failure to have an equity agenda. Now, equity agendas require staff and stuff. You can have arguments about which staff. I told you the main argument, I believe, was between community health workers and others. I said to the U of T students today, imagine if I had said, and others who had said at the beginning of this, between 1996 and 2003, when finally some of this work started to take off, what if we had said, you know what, to take care of AIDS in Africa, what you really need most is more infectious disease doctors. That's not true at all. What you need is the meds and community health workers and an equity plan to help people, again, get around these awful problems they have. Labor migration is the biggest one in Southern Africa, food insecurity, gender inequality, violence against women. There are ways for us to address this, at least in a and as physicians and nurses, right, as long as we work in partnership. That required staff and stuff. And of course, things that got said just 10 years ago, it's not sustainable, it's not cost effective, it's too expensive. Well, the same medications, by the way, that cost $15,000 per patient per year in the United States, they still cost $15,000 per patient per year in the United States, but they cost about $80 per patient per year in most of the places I work. Same meds. So how could you make one claim about cost effectiveness when the same medications cost $15,000 in one place and $80 in another? And the answer is, of course, you cannot, and you should not. And there's got to be some way for humans to actually determine costs, right? I mean, it's not handed down from extraterrestrials or, God or something. Thou shalt pay $7.92 for a tablet of fluconazole. At least I don't believe it. Now, there are some who make such claims, but... So all these notions of, helping other people, if they can pay for it, if it's sustainable, again, I understand where they come from, but they're not really the way to move forward the global health equity agenda. And there are other ways. I won't go on about them now so that we can continue our discussion, but this is the reason that we keep going back to this term accompaniment, right? If you started by saying, well, we'll do this and then fill in the blank. We'll treat this disease if we find the money, or we do this hospital that's been abandoned since the genocide in Rwanda, if we can have a contract. I understand the role for that sort of work, but it's not really the work of global health equity. It's not there are other and better ways to do this. And indeed, I've already praised the AIDS activists who never dithered about such matters and said, this is the right thing to do, it's the rights thing to do. It's very, very much how we move forward the agenda around that particular pathology. So the 1996 moment, even if we flubbed it, missed it for the better part of a decade, and of course, those people can't come back, right? It's not true that there hasn't been an enormous return on interrogating that approach and on rolling out another one, which is not based on ability to pay, but based on burden of disease and gap. Now, how big has that return been? I'm just going to give a couple numbers and then close with a thanks for some of the help in Haiti. First of all, these people who would come into the clinic, and even when we went from Haiti to Rwanda, it was good that we went with our Haitian colleagues. I mean, Mark Brender was talking about this yesterday. Of course we went with our Haitian colleagues. We learned how to do this work in Haiti. So we went to Africa, Rwanda, Malawi, and Lesotho. They were right there with us. And I think sometimes they were more credible mentors than others among us. Like I would always say, yeah, that patient will get better. And someone would come in weighing about 2 pounds. And they would say, yeah, he really will get better, or she really will get better. And we'd show them, this is what this patient in Haiti looked like before, this is what this patient looked like after. And this is a Rwandan guy, and I've said he has, of course, 2 diseases? Tuberculosis, HIV disease. His name's John. He said, of course you can use my photos. I'm kind of proud of them. But I've said to my medical students a lot, he goes from looking like Skeletor to looking like he needs Lipitor. And that's a high endorsement from an American practitioner. But this is just, you're saying, some of you are saying, well, what about other problems? Well, these vertical enthusiasms don't have to be used just to treat one illness. So that's one of the reasons I, have such respect for family medicine and family practice. The idea is you don't have one thing. What if it's used to strengthen the whole system, including the money that went through these first 2 major funding mechanisms, first 2 in human history, I'm claiming, right? And that's what Rwanda did, and that's why if you looked at all mortality declines, as opposed to just HIV mortality, you'll find 2 surprising, or at least uplifting, results. One is that when the public sector becomes the champion, that is, the public health authorities been the champion of rollout of a treatment like this one, again, we're talking about HIV and TB, and moves it through the public sector, with the help of many partners, and we're proud to be among them, you can expect steep declines in mortality, right? You have a treatment, you roll it out, people get better, And especially if they have community health workers by their sides. So these are probably the steepest declines in AIDS mortality anywhere in the world during these years. Much steeper than the United States or anywhere in Europe, and steeper than elsewhere in Africa as well. Now, the other thing is if you use that money to focus on not just AIDS, but on other problems, including primary care, you get the steep declines in all-cause mortality, not just among children, but among adults. And again, I keep waiting for this to be undermined by some really compelling example from elsewhere, but we've concluded in publishing these data that these are the steepest declines in mortality ever encountered anywhere and at any time in human history. What? Yeah, I mean, it's amazing, yeah. And that's because we have tools now, diagnostics, therapeutics, preventives, that we just didn't have 50 years ago. And in the places where those are needed most, if you have an equity plan to finance that and roll it out, you can expect these astounding declines. Now, even the biggest rebukes to optimism, like this one, which many of you here know, and again, this is my closing comment, and I'll be right on time, which is to say thank you. These were very difficult times. You know, Haiti had the same, even with its chaotic system, its multiple, governments, still was making progress if you look at child mortality, including HIV mortality. Again, a lot of money was going from the United States and the Global Fund into AIDS, tuberculosis, and malaria. Great. I was just writing an introduction, a preface to a surgery textbook, which I'm sure you all read as you did Women, Poverty, and AIDS. And, you know, I was saying that the claim that these diseases are crowding out cancer care for poor people or surgical care is absurd. It's not true at all. All diseases of poor people are neglected, right? Until we stop neglecting them. So all-cause mortality in Haiti was dropping as well, especially among children, not anywhere near as steeply as in Rwanda, but still, until, January 12th, 2010. Now, that was very difficult for all kinds of reasons that I can talk about if forced to. It's not, easy to talk about. We did have a lot of deciding to do as partners in health, however. And why? Because not only have we been in Haiti for over 20 years, that's where we started, that's where the biggest base of operations were, but we also had a lot of donations, gifts from people, unsolicited, and that had never happened to us before. We'd always had to, and so we had to decide, well, what is it we do? And if this was what we saw, I mean, this is the nursing school, and some of you have visited. You can imagine not many nursing students or their teachers survived that day. It's 4:53 in the afternoon. So we thought, okay, our mission is to link this unapologetic connection between service, caregiving for the sick, and teaching. That's what academic medical centers do, and the health problems of poor people. Well, we're going to build, of course, the thing we need to do after this earthquake. When the nursing schools and universities were destroyed, by the way, as were about 27 of 28 federal buildings, right? It was really something. We're going to build a medical center, a teaching hospital. And it varied, to go to a meeting of experts and say this. I mean, we had some people with just outright derision saying, well, that's silly. That's not a priority. Now, I should have learned to control my Irish temper, and I did, and I tried. I tried to be Canadian, but I thought, how could it not be a priority when their medical training system was just destroyed? I mean, they don't have any teaching hospitals now. The ones they had before the earthquake weren't good, but now they got none. How could it not be a priority? What do you think? The young people of Haiti don't want to be nurses, doctors, managers, dentists, all the things that we might like to do? Of course they do. Anyway, because we had supporters who did not interrogate our every decision with this undertow of censorious opinion, like, is it sustainable, is it cost effective, we went ahead and thought big with the Ministry of Health, and we said we're going to build this. Now, some of you laugh like, oh, come on, they didn't really do that. Yeah, oh yeah, we did. So this was the design. It took a while. When I say a while, by the way, some of you from around these parts were there. When I say it took us a while, we broke ground 6 months after the earthquake. It didn't take us that long, because we felt a sense of urgency, to get this up and running. And we knew we wanted it to be solar powered, right? We had actually already been in the course of converting all of our clinical facilities, which are public facilities, by the way, into solar. And our main collaborator, an American, died in the earthquake. He had already worked with us in Burundi, Lesotho, Rwanda. And we just thought, we've got to get this going. So this was the plan. And by then, of course, we'd seen a lot of charrettes. I didn't even know what the word charrette meant until the earthquake. And I said in a meeting, which wasn't, again, very Canadian of me, so many charrettes, so little action. Nothing seemed to get going. But we did get this hospital built, and so I want to say thank you. And this is the largest solar-powered... This is University Hospital, Mirebalais, the largest solar-powered hospital in the developing world. And I will just add one thing. When we said it's going to be called University Hospital, people said, you can't call it University Hospital? There's no university there. And we said, yeah, yet. But there will be. Why can't you start a university with a hospital? Who said? Again. Anyway, my last image, and I went 2 minutes over, is to say just because we're concerned to build proper hospitals does not mean we're ever going to forget that the majority of care can and should take place outside of hospitals. The lesson of Haiti during the earthquake, or Rwanda during the genocide, or you go through the list that you have in your mind, or the Boston Marathon bombings, which occurred at the time of the inauguration of the hospital last year. It's like, when you're injured or hurt, or sick with cancer, malignancy, leukemia, say, or whatever, or a complicated delivery, you do need a hospital. And choosing between hospitals and community-based care is a silly proposition. We can't do that. We need community-based care. We also need clinics and hospitals. So my last image is, again, back to accompaniment. Accompaniment requires those 3 components, just as family medicine does. Community health, clinic-based care, and hospitals. It's not the only way to address poverty, and we never said that. But we said investing in healthcare is an important means of addressing poverty, and without doing so, we will not break that cycle of poverty and disease. When we do so, and in a way that links our efforts to training, education, these investments, we will break the cycle of poverty and disease. Thank you.